We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to the ERA podcast, A Pinch of Salt. I'm George Kosmadakis, and the subject today is the approach to conservative care for end-stage kidney disease patients. The subject is gaining importance in the national and international congresses, as well as scientific societies, reflecting the important unmet needs concerning the detection, diagnostic workup, therapeutic strategies, and proper outcomes for this ever-increasing group of patients. Our guest today is Professor Holly Koncicki, Associate Professor at Mount Sinai Health System, New York, USA, and will help us decipher this subject. Professor Koncicki, thank you very much for being with us today in the Pitch of Salt.
Thank you so much for having me.
I have to tell our guest that you are a specialist on conservative care, and you have three different specialties. You have a specialty of nephrology, of course, internal medicine, and also conservative palliative care. So you are one of the only nephrologists in the world who has accredited specialization on this matter. So we are very happy to have you with us today.
Thank you so much.
I will start, as always, with an apparently naive question, which is conservative care considered a therapeutic option for patients with end-stage kidney disease today?
Yes, so I would say absolutely. And I think conservative care is really growing in familiarity amongst nephrologists and other clinicians. And it may not be something that every patient with chronic kidney disease would consider, or it may not need to be offered to every patient with chronic kidney disease. But there is specific populations in which this is an active and acceptable treatment of advanced kidney disease. And I think that it might be helpful to frame what conservative management is. So conservative management is not the care that somebody receives when they, quote unquote, refuse dialysis, which I really dislike that terminology. Patients have a right to make treatment in regards to their therapy choice. And conservative management is really kind of the integration of palliative care and chronic kidney disease care. So while we still may be treating things like volume status or electrolytes, we are also focusing on early identification of symptoms. We are focusing on the psychosocial aspects of care. We are engaging patients and families in advanced care planning and also identifying maybe clinical changes or changes in functional status that may necessitate changes in overall care needs.
Right. So we are talking about palliative and CKD combined care, psychosocial care, and you are talking about a target population. And can you help us define which are the criteria with which you define the target population for these different kinds of treatment?
Sure. So, I think it's a broad question, and I don't think that there's any perfect answer to it, but there are some ways that we can be guided to help narrow down the population. And I think when we think about offering any type of medical therapy, including dialysis or conservative therapy, we want to think about what are the outcomes of that therapy that we're hoping to achieve. And often, those outcomes are in two big buckets. One of those buckets is improving the quantity of someone's life or their survival. And the other big bucket is improving the quality of someone's life. And there's a lot of research focusing on these things and comparing conservative therapy and dialysis. So, for example, in the terms of quantity of life or survival, there are numerous studies, all which are outside the United States, so we can't take credit for them, that shows that there are certain populations that there is unlikely to be a significant difference in survival with dialysis as compared to conservative therapy. So what populations are those? So those are our older patients. So some studies will say over 75 years old, some will say over 80 years old, and in patients that have multiple comorbid conditions or with heart disease. So I think that those are really the main populations that I would focus on usually is our older patients, whether it be over 75 or 80, and also those patients that have multiple comorbid conditions.
Right. So, we are, as we say, victims of our success because with a very optimal care of CKD, we have managed to prolong the non-dialytic life of our CKD patients. So we have patients that are arriving at the end stage kidney disease in a much later age. So this question is becoming more and more important and more pertinent. You have identified quantitative and qualitative characteristics for these patients, and you have identified patients over 75 or 80 years old with comorbid conditions and or heart disease. So are these patients entering in this specific group where we should discuss with them, where we should ask them, should we advise them?
So I think that's an important question. And I think everyone's approach is a little bit different. I think that in our patients that we're caring for, it's really important to elicit a couple things when speaking with them. So one of those things is, what's important to them in the big picture. So in terms of their quality of life, what is most important to them? And, we really don't know what patients value unless we ask them. So, for example, if I were to ask you, what do you think the number one health outcome priority of patients with chronic kidney disease is? One may assume that it's living as long as possible. But there was actually a study that came out a couple of years ago looking at patients over the age of 60 with chronic kidney disease stage 4 and 5 and asked that exact question. What is your top health priority? And it may be really surprising to hear that maintaining independence was actually the number one health priority. And survival was second. And in half of the patients, survival was actually ranked the third or fourth health priority. So really getting to know our patients, exploring their narrative, finding out what is most important to them in terms of their life, is going to help us if we do make a medical recommendation about therapy. So that's really the first thing that I would say is to elicit. The second thing is to really discuss what the feasible outcomes are of the treatments that are reasonable for them, whether it's dialysis and conservative management, and talking about what life would look like day to day and what life may look like in terms of overall survival. And, you always want to make sure that the people that are involved in that conversation, whether it's just the patient or a patient and a caregiver or healthcare proxy, wants to hear survival information because some people may not want to hear that. So you always want to just make sure that, people want to hear that information. And I think that those are all really important things to explore with patients, to outline with patients, and then to get a sense from them, of those treatments. What do you think fits best with your life and with your goals? And some patients and families may be very clear, and some may ask for your recommendation. And I think if they're asking for your recommendation, it's okay to share what you think would fit best with their goals. And, if they don't ask for your recommendations, but you feel very strongly that you're worried about the outcome of one treatment versus another, you can ask patients and families, is it okay if I share, what I think would best fit with your goals?
So you don't exclude that a doctor might position himself in this discussion.
Meaning that a doctor may say
Might
dialysis is
might
not
have an
for.
might have an opinion on this.
No, I think that a doctor often
Doesn't
will
shock you.
have an opinion. You know, I think that when somebody comes into our office, you know, a lot of times we have this, you know, gut instinct, this gestalt that, you know, I'm really worried about how this person might do if they went down the dialysis road. But, you know, I think that it's really important to hear from patients and families about what they value and what they're worried about. And, you know, I think often making that recommendation, you know, I'm really worried that if you went on dialysis, you know, you would be spending lots of times interacting with medical facilities in the hospital, having procedures done. And, you know, if independence is important to you, that's going to really interfere with that. And it's unlikely that it's really going to, you know, improve survival.
Yeah,
You know, so framing it in that way.
yeah, yeah. It's very interesting. You know, what you said made me think before about the priorities. Made me think of the song initiative where we had the most a listing of the most important factors for the patients and for the doctors, and you could see that there was absolutely no correspondence between the two groups. And the second thing that you made me think was I read once a study where they had several tools with which they were predicting survival on dialysis for patients against the gut feeling of the doctor,
Mm-hmm.
of the treating nephrologist, and the one who won was the gut feeling of the treating nephrologist. And as you said, you know, sometimes we see some patients who we are discussing about their options, and you know, we all have a gut feeling, and this is a little bit liberating because until now I was trying to censor myself and not talk about these options. So we are a part of this uh, group that discusses what should be done. So we should have an opinion, probably.
Yeah. Yeah. And that study that you were talking about, you know, I think it's the surprise question. So it's, you know, would I be surprised if this patient died
Yeah.
within the next
Yes.
6 months or a year?
Exactly.
And it was validated in chronic kidney disease stage, I believe 4 or 5, in hemodialysis patients and in peritoneal dialysis patients,
Yeah.
in which when the doctor said, no, I would not be surprised, you know, those patients were at a higher risk of mortality. So, yeah,
Yeah.
it's true. You know, I think that we are, you know, we are the ones that are really having this conversation with patients. So I think we are the ones that, you know, hopefully are becoming more comfortable having conversations. And as we get
Yeah.
more comfortable, then providers outside of nephrology may also get more comfortable.
Yeah. So of course that doesn't exclude what you said. Of course, ask the patients what are their priorities, explain them which are the feasible outcomes. Before I pass to the next question, which is the best moment to start this discussion? Uh, I mean, at what stage of the CKD? When early, when we pass under 20 mLs per minute of GFR, which is the best moment, in your opinion?
I think that's a really tough question. I think like this is not a conversation that is going to happen in one visit. You know, this is something that I
Yes.
think happens in pieces as you build a relationship with someone.
Mhm.
And I don't mean to segue, but I think that this, you know, you also have to take into account the likelihood of someone progressing to dialysis, because I think a lot of our older patients sometimes are referred to nephrology, and is it true chronic kidney disease? Is it an age-related decline? Are they at a real risk of needing dialysis
Yeah.
in their lifetime, right? Because you also don't want to cause anxiety with patients in
Yes.
bringing up things that are not potentially they're ever going to have to decide. But I
Of
think,
course.
you know, in that being said, you know, I think that AKI or kidney injury sets off a decline in kidney function in older patients where we may not expect them to have dialysis come up in their future. So I think that, if you think someone is at high likelihood of progressing, then usually I would probably start discussing in the CKD, 4 range if they're referred to me at that point.
Okay.
Just to kind of get an early sense of what they're thinking and how they're feeling about things, and also kind of getting a sense of, what are their symptoms early in chronic kidney disease? Because so many of the symptoms of uremia that trigger us to start dialysis are symptoms that we see with other geriatric syndromes, with frailty, with other
Yes.
comorbid conditions, right? So if those symptoms are present early in CKD 4 and they're still present in CKD 5, I'm not going to say that dialysis is going to make them necessarily feel better because those symptoms were pre-existing. So I would try to have those conversations earlier in the patients who I think, are at a high likelihood of progressing.
Right.
Is the short answer.
So yeah. So it's you start at stage 4, step by step. At the same time, you try to create a relationship of confidence with the patients, and you advance from one day to the other. And
Right.
I will ask you now the last medical question, which is, are there different ways that this conservative care could be delivered?
Yes. So absolutely. And I think that, there's really no standard of care delivery of conservative therapy at this time. I think that every country, every practice, every nephrologist, may have this care be delivered a little bit differently. So, some conservative care practices may have a palliative care physician or a nurse practitioner or a social worker within their practice. And that gives you that multidisciplinary team that, is so important in palliative care. Other nephrologists like myself, I am palliative care trained, but I will really try to work with the primary care doctor and the social worker that's in that office to try to coordinate care for patients. So in that regard, the aspect of how care is delivered will really vary depending upon the practice. The second way it will vary is, again, by the goals of the patient. So some patients, will say, I don't want dialysis. I want conservative therapy. I want to come in for blood work. I want to keep getting medications for anemia and, phosphorus and acid, our acid-base balance and all of those chronic kidney disease things. I will take all the medications. I will get the blood work. I will keep coming to see you for that. Other patients may say, I don't want dialysis. I want to focus on my symptoms and how I feel. The numbers are not so important. I really want to limit blood work. I want to limit medications and polypharmacy, and they may say, I really just want to focus on my symptoms. And those are two really different ways that conservative care can be delivered. One looks really closely to the chronic kidney disease care that we've been delivering, and the other one looks more, palliative and symptom focused.
So you issue a kind of treatment plan with the patient, depending on his wishes and his needs, whether you want to be CKD centered or symptom centered, and you adapt your protocols depending on this plan. Is that so?
Right. Yeah. So with
Right.
the CKD center, we're still managing symptoms, but we are still checking blood work and, adjusting medications in that regard. And the symptom focused, maybe there's some benefit to, treating anemia in terms of symptoms, but, maybe the phosphorus binder isn't going to be the most important thing in their overall care if they're focusing on symptoms.
Yeah, or itching or anything. Right. Very, very interesting. Well, I will pass on now to the most get to know you personal question. Uh, we ask everybody, and the answers are always very interesting. If you were in a desert island, Holly, which
Mhm.
book, luxury item, and two songs would you take with you?
So this was actually the hardest question of all of them. I think in
You're not the
terms
first to
of
say it.
in terms of books, if I'm on a desert island, I want something light and fun.
Yeah.
So I would probably um, so like Emily Giffin is an author that has a series of kind of rom-comish books. So I would bring one of those, probably Something Borrowed, which is a book that I read countless times while sitting on a beach. So I'd probably bring that with me. A luxury item, I would just need like a really good coffee maker and some really
Coffee
good
maker.
coffee.
Oh, you're the first. Me too,
Yeah, I
probably.
mean, I'd probably need some electricity for that, so maybe it'd have to be solar powered, but like that's really what I would need. Um, and my two songs, I'm a huge Michael Bublé fan.
Michael
Michael, if
Bublé,
you're
yeah.
listening,
Yeah.
I think
Which
like
ones?
of any of his songs I would love, but probably Home. And then there's like a song Crazy that I would probably bring those two with me.
Okay, because at the end of the year we'll do a playlist, and we need the specific songs. That will help us a lot.
Yes.
So, thank you so much. Dear colleagues, as you see, conservative care is a legitimate therapeutic option, and significant efforts are needed to develop and standardize an evidence-based framework for its implementation. More up-to-date international guidelines are needed to accompany efficiently this sensible group of patients. Stay with us for more podcasts in all digital platforms. Take care.